Hi, my name is Shahid Ahmed. I'm one of the assistant professors at University of Vermont. And today it's my pleasure to talk about this very interesting topic. We're going to be talking about how we can harness the immune system to fight cancer. And this is something that's very close to my heart, and I'd love to share this with you. So I don't have any disclosures. So today we will be talking about a brief history of immunotherapy, where it came from, and what we've known about the immune system and how it deals with cancer. We're going to talk about the role of the immune system in cancer surveillance. And then we're going to talk about some of the moonshots that have happened in the past few decades and how immunotherapy drugs have been approved for cancer. Lastly, we're also going to talk about something very interesting that's coming up, which is the role of diet and bacteria with how the immunotherapies work, and how can antibiotics or probiotics or vitamins change your microbiome and response to immunotherapies. And we're also going to be talking about the future of immunotherapies and where we can see ourselves hopefully in the next decades. So it all started from Dr. William Colby, who was a surgeon in New York back in the 1800s. And he used to operate on people's sarcomas. Sarcoma is a cancer of the bone. And he was upset because his patients would die because of the cancer. And he did a literature search from 18th century texts. And he found out that there were a few people who would actually do okay if they had an infection going on at the same time. So he thought, how about I get some bacteria and inject them into the tumor and see what happens. He was thinking that by injecting the bacteria, he might be able to stimulate the immune system to go and fight the cancer. And so he concocted this cocktail of bacteria, and it was called the Colbys toxin or Colbys soup, and he would inject these into patients. So the first time he did this in 1893, it worked great. And he published his report. This was the first report of an immunotherapy being used for cancer treatment. And then he went on to do it for a lot of his patients thereafter. He published all of that, but there was a lot of skepticism because nobody knew how this was working. Why would injecting bacteria cause the tumor to shrink down? And so he was kind of chastised for a while. But in the next century after that, there has been a lot of advances standing on the shoulder of Dr. Colby, where people have kind of theorized and then later on gone to prove how immunotherapies work. So one of the first people to do that was Dr. Paul Ehrlich, who came up with the hypothesis that our immune system is looking for the cancer at all times and is already always on the prowl and finds it and takes care of it. And this was only a hypothesis back in the early 1900s, but there has been a lot of research since that time, and things have come along quite well. So I want to talk a little bit about how that's happened. So you can think of the immune system as kind of the policeman of the body. They kind of are always looking for foreign things that they can find and eliminate from the body. And these are often bacteria that they're eliminating or other foreign entities. But also the immune system is responsible for doing surveillance of cancer cells. And what is a cancer cell? A cancer cell is a cell that used to be normal, but then there was a mutation that happened and it would change and start to grow and grow without any checks or balances on it. And typically, a growth like this is detected by the immune system and it takes care of it. There are several different types of immune cells or different types of the brigade that's responsible for doing this surveillance. There are the natural killer cells or the cytotoxic cells. Both of these are responsible for killing cancer cells or bacteria when they're found in the body. But then there's also cells that have the job of retaining a memory of what has happened. So if a cancer cell is detected and the immune system takes care of it, the memory cells will then remember that. And so if ever that cancer cell shows up again, the immune system is prepared to tackle it. However, there are also some tumor suppressor cells, which are part of the immune system. And the reason to have these cells is to calm down the immune system when it's overacting. And so the primary job of these cells is to do that. But sometimes, because they calm down the immune system too much, that can lead to the cancer cells growing. So we'll talk a little bit about the normal life cycle of how immune system kind of treats cancer. So initially, when a T cell or an immune cell or the policeman of the body detects a cancer cell, it will go and find it and attack it, and then kill that cancer cell. It will then pick up the remains of that and kind of deliver it to the second place over here, which is the lymph node. And that's where all the other remaining immune cells live. So you can think of the lymph node as like the police station of the body. So all the immune cells will pick up the cancer cell debris and bring it to the lymph node, where the remaining immune cells will kind of convene and that will be presented to them. After that, the immune cells get ready to be recruited, and they go and find, now that they know what the cancer looks like, because they've looked at the debris of the cancer, they will then go and find these cancer cells and attack them. And they have different molecules on their surfaces which allow them to do that. And so by killing more cancer cells, you can see the cycle starts again, because you have more debris from the cancer cells now. And then again, your immune cells will pick that up and take it to the lymph node. So it's this constant cycle, a dynamic constant cycle of the immune system doing surveillance of the body and looking for cancer cells. Now, I talked a little bit about the molecules on the T cells, or that allow these immune cells to detect the cancer cells. There are the activating molecules, and these basically, if a T cell has that and it binds to the cancer cell, the T cell will attack the cancer cell and kill it. But there are also these inhibitory molecules. These are responsible for telling the T cell not to kill the cancer cell. And really the purpose of these in nature is so that the immune system does not have complete impunity to attack whatever it wants. And often these molecules are present on our normal cells to prevent the immune system from killing normal cells. But sometimes cancer cells can learn to kind of do what a normal cell does and produce these molecules, thereby telling the immune system not to attack it. And that's how cancer cells can grow. So as an analogy, I like to think of it as if the cancer cells can learn to put an invisibility cloak on itself. And now your immune system can't see it because of that. So, we all get cancers in our lives, and these are often removed by the immune system, and we don't even know about it. That's the theory of the immune surveillance that we've been talking about. And there are three basic phases of how a cancer forms despite this surveillance. The first is that the cancer cells are eliminated by the immune system, but sometimes a few cells might remain behind because of certain characteristics of those cells. And because of that, because they share those characteristics over time, because they've not been killed, they grow over time and can become immune resistant, or the immune system can't see it. It's like that invisibility cloak on the cancer cells, and the immune system can't see it. So that's where some of the most newest advances have been made, and which have been very exciting. And some of that work has been done here in the US by Dr. Jim Allison, who described these molecules on the T cells, as well as Dr. Honjo, at Kyoto University. And both of these people received Nobel Prizes for this in 2018. But because they discovered that invisibility cloak that the cancer cells can put on, we now have treatments that peel off that invisibility cloak, and now your immune system can see the cancer cells again and attack it. So this is what they discovered, was that these T cells can be inactivated by the cancer if they express certain molecules called the immune checkpoint. But if you block the checkpoint, then the cancer cell cannot evade the T cell, and the T cell can see the cancer and attack it again. So it really is the journey that Dr. William Colby started 125 years ago, and Dr. Allison and Hanjo, built on and discovered these molecules and then the treatments afterwards. So we'll be talking a little bit about what those treatments have kind of come to. So there are several types of immunotherapies that are available now. And everything that I'm going to be talking about right now is what is considered standard of care, meaning these are not experimental treatments anymore. They are in our practice and we use them all the time. And at the end of our talk, I'll talk about some experimental things too. But I want to first off just share everything that has happened, which is really remarkable in the past 10 years. And share some of these advances that have now come to our clinic and are routinely being practiced. So we talked about the checkpoints or the invisibility cloak and the treatments for it. And so we have these newer drugs available that kind of inhibit the checkpoint inhibitor. The checkpoints, and your own immune cells can see the cancer cells. And there are two main molecules that we have drugs for. One is the CTLA-4 molecule that was discovered by Dr. Jim Allison. And the other molecule is the PD-1 molecule that was discovered by Dr. Hanjo. And we have drugs now that block both of these molecules to boost your immune system. Now, the first treatments for which, the first cancers for which these treatments were utilized was about 10 years ago. It was used in melanoma. And they used it in some patients who had cancer that had metastasized to multiple places, including the brain, liver, lungs, really stage 4 cancer, and something with which their prognosis was really poor, on the order of a few months. And some of those people who got these drugs back then are still alive because the immune system was activated and it would go fight the cancer and then develop a memory of the cancer. So the hope with the immune therapy is that it's not only just treating the cancer, but also hopefully treating it for a long period of time. While this doesn't happen in everybody, that certainly is the hope, and we've seen this in some patients. Certainly nothing like this was ever done before. And certainly with chemotherapy, you can sometimes get a benefit, but not a durable benefit, and almost always the cancer becomes resistant to it. But with immunotherapy, we started seeing some people for whom the cancer did not recur after that. So this was kind of unprecedented and had never happened in our field before. And this all started with the treatment of melanoma, which is a skin cancer. Since that time, there have been multiple drugs that have been approved for multiple different kinds of cancers, because as soon as they found out that this was what was happening in melanoma, they tried these treatments on multiple different kinds of cancers. And now they're available for a lot of cancers, including lung cancer, bladder cancer, as well as some other skin cancers. There's a multitude of indications for these drugs now. And while they work to a different degree for each cancer based on its characteristic, but this has kind of changed our field in the past 10 years or so. I also want to talk about some other, immunotherapy treatments. So the checkpoint inhibitors that we just talked about, these are the most commonly used drugs that are used very commonly in our clinic these days. But there are some other treatments that have also come along the way, which are very novel, and I want to share them with you. One of them is Sipuleucel T, or active cellular immunotherapy. What this is that in patients with prostate cancer, for example, what's happening is that their immune cells are not recognizing the cancer. So we remove their immune cells. So we take white blood cells from their blood, and we introduce those white cells. We kind of train them outside of the body by exposing them to this protein, which is found in prostate cancer. So we're kind of showing the immune cells what a prostate cancer cell might look like. And after training those immune cells, we kind of clone them and not clone, but grow them. And after growing them, they've kind of, you've engineered them to learn more about the cancer, and then they've kind of grown a little bit. And then you infuse it back into the patient. And this seems to work for prostate cancer. So really exciting treatment in that world. Another kind of immunotherapy is utilizing this virus, which is Oncolytic, meaning it's a virus that can attack cancer cells. We use this a lot in melanoma, where we take this virus that's harmless because it's been engineered not to cause infection in a patient, but it still has the characteristics of it that allow it to kill cancer cells. So we'll inject this into a patient's tumor, and sure enough, the virus goes in and attacks the cancer cells and leads to the cancer cells dying. And then if you remember, we talked about the cancer immunity cycle. That whole cycle starts happening, that your immune cells will come here and kind of clear the debris and learn from this. And then your immune system can start having, your own immune system can get boosted and start having a response against the cancer. So this is really novel, that you're trying to supplement the immune system and kind of help it along the way by using these viruses to kill cancer cells in the first place. Another very exciting newer treatments, and it's been in the news quite a lot, are CAR T cells. CAR T cells are these immune cells that are now approved for a few blood cancers and lymphomas. And the concept there is that you would remove a patient's immune cell. You would then kind of train it outside of the body by introducing these viruses that are designed to teach the T cells to produce certain markers. And those are the markers that can allow those T cells to identify the cancer cells. And after your T cells have been engineered outside, you clone them and infuse it back into the patient. So you've kind of taken these T cells, which were not doing the job that they should have been doing in the first place, and you take them out of the body, retrain them, and then put it back, and they start working. So this treatment has been now used as standard of care for a couple of cancers, but a lot of clinical trials happening in a lot of other cancers, trying to figure out if there's a role in that. Very exciting. And lastly, I wanted to talk about this another newer treatment that's now becoming available, is where you take these antibodies that have two arms. One arm attaches to the cancer cell, and the other arm can attach to the immune cell. So by having two arms, it's bringing together the cancer cell and the immune cell and bringing them in close proximity to each other, and then activating the T cell after that and causing an immune response. So really exciting stuff that's been happening. So I've gone over a few of the immunotherapy drugs that are available out there. There's a lot more happening. There's a lot more that's experimental, but very exciting time certainly to kind of be living in right now, especially as an oncologist, and especially for a cancer patient. Now, what kind of side effects do these treatments have? And so really, if you're boosting the immune system lives in the entire body. So it can sometimes attack your own organs. And you can think of it this way, that when your immune system is fighting the cancer, sometimes instead of fighting the cancer or in spite of fighting the cancer, it can also attack your own organs. And it's kind of like friendly fire. And because the immune system lives everywhere in the body, you can have the immune system attack the kidneys or the colon or the skin. The most commonly seen things are skin for the most part, the colon and the lungs that we kind of monitor very closely, but it can really attack any place. The good thing is that we are now learning how to deal with these things. And we have drugs that can calm down the immune system, and sure enough, these side effects get better. If you look at, I have several, patients who are getting these immunotherapies, and by and large, most of them don't have a lot of side effects. That's very different from previously, when we used to use a lot of chemotherapy. And those patients, a lot of them don't have side effects, or maybe the most common side effect would be a little bit of a rash or feeling slightly tired. But certainly not a lot of patients have nausea, vomiting, losing their hair, kind of like those things that you would expect with chemotherapy. Patients with immunotherapy don't have those toxicities. And all these side effects that I've listed over here, they're rare to happen, but when they happen, we're learning to kind of treat them when they happen. Next, I wanted to talk about the role of bacteria and how that affects the immune system and what we've learned so far. So if you remember, this is where all of this started, with Dr. Colby injecting bacteria into tumor cells. But the question now becomes, do the bacteria in your gut, or the bacteria that are already living in your body, do they have an impact on the immune system, and how does that happen? And in the past 10, 20 years, we've learned a lot in that field as well. So we now know that there are certain bacteria that if you have those bacteria, you're more likely to benefit from immunotherapy. And if you don't have bacteria in your gut like you're supposed to, because you've gotten antibiotics, then the immunotherapy might not work. And so once we found those things, we were kind of intrigued as to why this happens. So really, you should think about it this way, that there's bacteria that live everywhere in our body. There's probably more bacteria in our body than our normal cells. And they make up a lot of, they have a lot of benefits that are given to our body. So the gut microbiome is the one that's been studied the most. And you can think of it this way, that it's kind of like the area that is exposed to the body, because you eat, drink, all the time. So you're exposing the body to those bacteria. And within the lining of the gut, there are these immune cells kind of sitting there, kind of watching out for these bacteria, just to make sure that they're not going to cause any harm to the body. So the gut can be thought of as the training ground for your immune system, because it sees so much bacteria in that area that it learns from those bacteria. We have learned now that the more diverse your bacteria in the gut, that the better your immune system is trained. And if you have a lot of bacteria that are of different kinds, then your immune system has seen a lot, and it's, as a consequence, stronger, not just in fighting any harmful bacteria, but also in fighting cancers. We've also found that for people who get immunotherapies, where we're boosting the immune system, There are people for whom it works and for whom it doesn't work. And we found that for the people for whom this works, they have these specific kinds of bacteria in their gut, whereas for the people for whom the immunotherapy did not work, they had these other bacteria here marked in red. So this was very fascinating because it seemed like that the bacteria in the gut had a role to play in when immunotherapy would work. And sure enough, when they would take the stool, the bacteria of mice for whom immunotherapy was working, and inject it or give it to mice that for whom immunotherapy is not working, that their immune system would get activated and the immunotherapy started working after transplanting the bacteria into those mice. So this was certainly very fascinating, and there are studies going on right now where they take the stool of patients for whom treatments are working and transplant that stool into other patients for whom treatments are not working. And the hope is that we are able to get those people for whom the immunotherapy is not working, we're able to get some benefit over there too. So that's very fascinating. There have been numerous studies that support a link between the gut microbiome and the response to immunotherapy, not just in a few cancers, but in melanoma, in kidney cancer, in lung cancer, and various other cancers. And so, we're still kind of learning about this, but certainly there is a connection there. So what can be done about the gut microbiome? How can you have a gut microbiome that's healthy, that can keep your immune system going well? And there are some things that you can change and some things you can't change about your gut microbiome. For example, it changes with your age and your sex and your genetics. But those are things that you cannot change. But there are certain other things for which the immune system, the gut microbiome changes all the time because of the diet that you're on, or medications. For example, antibiotics can kill bacteria and change your microbiome. Similarly, weight can have an impact. Where you live can have impact. And then psychological factors also are thought to have an impact. So they did this very interesting study that I wanted to talk about, where they took people who were African Americans and some other people who were in Africa, and they would they swapped the diets. So the American Africans were given an African diet, and the Africans were given an American diet. And they basically looked at their gut microbiome and how it was before they made this intervention and after. And what they found was that the gut microbiome completely changed, that the Africans started having an American gut microbiome, and vice versa. And there are some implications to that, because there are now studies showing that a vegetarian-based diet, a bean-based diet, for example, can result in some beneficial bacteria that can cause the immune system to be more stronger. Whereas another thing there is high fiber diet. If you are on a high fiber diet, which is contained in a lot of fruits and vegetables, those people are more likely that their immune system is going to be robust to fight cancer. So it's certainly something that we learned from this study. Another thing to consider is that bacteria are not just present in our stools, but almost in all of our organs, in most places, even the places where we think are completely sterile. We've now found that bacteria just normally live there. That's how we've evolved as creatures to be living with bacteria. And so they have found bacteria in people's coronaries, in breast cancer, in bladder cancer, in lung cancer, and even in normal tissues. And the question is, are those bacteria harmful, or are those bacteria beneficial? So they've done studies where they've shown that certain kinds of bacteria in your tissues are beneficial for your, in terms of the treatments of cancer, but other types may not be. In this particular study that was done at MD Anderson, they looked at patients with pancreatic cancer who lived for a long time. And they were trying to figure out if the bacteria had a role to play in it. When they compared the bacteria of people with pancreatic cancer, they found that the folks who lived the longest had a specific kind of bacterial strains listed over here as these last three, compared to those who did not live long enough, did not have these three bacteria. So there is certainly some implication here that the immune system might be might have an interplay with these bacteria that are present in our organs. You know, this is just hot off the press last year, and so there's more work that's going on with the microbiome. So that brings us to an important question. What do we do about antibiotics? Because antibiotics can kill bacteria and change your microbiome. And they've shown in a study here in melanoma patients that folks who needed antibiotics for whatever reason did worse than people who did not get any antibiotics while they were getting immunotherapies. And the wisdom here is that if you have a disease for which you need antibiotics to survive, of course, by all means, it makes sense to take antibiotics. But it does kind of argue against the overuse of antibiotics when they may not be needed as frequently. Again, antibiotics also kind of led to more side effects in people getting immunotherapies. So that was also very interesting to find. Similarly, probiotics, you know, are commonly used, and you know, in culture, it's felt that they're beneficial things. But if you think about it this way, they're changing the diversity of your microbiome because you're introducing these bacteria from the outside that may be very different from the bacteria that you naturally have. And over time, these can dominate those other bacteria and decrease the diversity of the microbiome. So there is a concern that using probiotics could lead to reduced effectiveness of immunotherapies. There's also some role of vitamin D and how supplementing with vitamin D can actually prevent some of the side effects of immunotherapy. That's very interesting. So what, I guess the biggest question is, what can we tell our patients right now? And, you know, while we've been saying a lot of these things for many years, which is to be healthy, stay active, I think there are some newer things that we can now start saying in relation to using immunotherapies, because they're becoming so common and we use them all the time in our clinic. Number one is that eat a diet that's rich in whole grains, vegetables, fruits, and beans, because that seems to change your microbiome in a very beneficial way. Number two is to limit consumption of fast foods and other processed foods high in fat, starches, or sugars, because they can adversely impact your microbiome. And number three is to be careful about using antibiotics and over-the-counter probiotics. It doesn't mean that you can't take antibiotics, but just being prudent about using them and use it only when necessary. So these are some things that we've kind of learned so far, and the hope is that with us learning more about the microbiome, that we could even maybe try to use it to our advantage. So where does that stand us in terms of the future of immuno-oncology? You know, I want to talk a little bit about how successful these immunotherapies have been. So here I've listed all the types of cancers for which immunotherapy has been approved and the year in front of it. And this is just staggering. There's multiple types of cancers: melanoma, lung cancer, kidney cancer, colorectal cancer, Merkel cell, which is a skin cancer, lymphomas, breast cancer, urothelial cancer. And this is really exciting that we now have treatments that work sometimes regardless of the cancer diagnosis. And we're kind of using them kind of all over the place, which is nice. However, the benefit of immunotherapy doesn't happen in everyone. And that's something that we need to change. While there has been a lot of advancement since 2010 or 11, when the first immunotherapy was approved, there are still patients that you see here in this box. These are all the patients on the right side for whom immunotherapy worked. But all these patients over here, immunotherapy did not work. And the reasons we don't understand completely, but we're trying to understand that. And that's where the future lies, is that we want to get the benefit of immunotherapy to these folks over here. For certain cancers, there's only a minority of patients that respond to these treatments. And one example is bladder cancer. So in bladder cancer, only about 20 to 30% of people who are getting immunotherapy in the second line setting will have a response to it. Now, this is very different from melanoma or other skin cancers where the rate of response is very high. But certainly the benefit has not extended to all tumors. And the reasons for this could be multitude. One reason could be that the cancer cells are kind of surrounded by these other cells that we call the microenvironment of the tumor that are preventing the immune cells from coming in. Another reason could be that while we know about certain invisibility cloaks, the checkpoints, but we may not be aware of some checkpoints that are yet to be discovered. And another thing could be that the immune cells talking to each other in the lymph node might not be happening as well as we want it to be. So there are several things that we're kind of working on trying to figure out why these treatments don't fail. And what we found is that there's these three types of tumors. There is the tumor, to put it in context, the dark spots here are the immune cells, and the lighter spots are cancer cells. And so there's a type of tumor that has a lot of immune cells in it. That's a cancer that the immune cells recognize very well. And for these folks, when we give immune therapy, it works really good. However, there are other types of cancer where the immune cells have recognized the cancer initially, and they've come to the periphery of the cancer, but they're unable to go inside and make an impact. And we call this the immune excluded tumor. Finally, there's a type of cancer for which the immune cells don't recognize the cancer at all. And it's almost as if it's completely invisible to the immune system. And we call this the immune desert. And we've now kind of learned more about these subtypes and trying to figure out why, what are the bases, the scientific basics behind these, and try to design treatments for it. So there are several trials happening all around the world, that are very exciting, and trying to get that benefit of the immunotherapy to all patients and not just a few. And some strategies are also being used here at UVM. So we have clinical trials that are available that use the combination of immunotherapy with other drugs to try to increase its effectiveness. We're trying to use drugs to bypass the resistance to immunotherapy. Then we're also using immunotherapy earlier in the course of patients and not waiting till it's become stage 4. And this is where we use immunotherapy before and after surgery for localized cancers. And so all of these approaches are experimental at this time, or some of them are, and are being investigated in the context of clinical trials here at UVM and also at a lot of other places. So what is the goal of all of this? Well, if you look at these two lines here, the blue and the purple, that's how what used to be. So you can think of it this way: if the line drops off sooner, that's a reduced life expectancy. And previously, with chemotherapy, we were able to extend the life expectancy a little bit, but people would still kind of succumb to their cancer. And long-term survivors were very rare. But with immunotherapy, because it has the additional advantage of developing a memory of killing the cancer cells. Sometimes the benefit can be extended over time. And so there are people who are having a long-term benefit here and are surviving and not succumbing to their disease. However, it's not everyone. There are still a lot of people who are not benefiting from immunotherapy. And these newer treatments, the combination treatments and utilizing other treatments, the hope is that we will be able to extend this benefit to all of those people as well. This is just a busy slide, just kind of looking at all the different checkpoints and all the different masks that a cancer cell can wear, and all of them that we've identified so far. And for a lot of them, we have treatments that are available or are in clinical trials right now. And there's a very complex interplay between the immune cells and the cancer cells, and learning more about that is certainly going to pave the way. The hope eventually is that we're not just able to give immunotherapy to everyone, but to identify who's going to benefit from it and who's not going to benefit from it. And if we can identify who's not going to benefit from it, we can try alternate approaches so that they do benefit from it. And then for some people, to identify for which it's not going to work at all, to exclude them from immunotherapy and to try something else for them. And the way we're going to get there is by doing more testing and by looking at the genetics of the tumor, the microbiome, and the various things that a tumor secretes into the bloodstream called cytokines. And by looking at these things and understanding the tumor better, we would be able to design more treatments that are more tailored towards everyone's specific cancer rather than an enveloped approach. So with that, I'd like to end my talk. Thank you so much for hearing me, and we can take questions. Thank you.